Hi, this is Doc Ina and welcome to my lecture on endometriosis. To download my lecture deck, please go to my WordPress site, Doc Ina Ubigaine. Main reference for this lecture is Comprehensive Gynecology, 7th edition, Chapter 19. And this is the outline of my lecture. So what is endometriosis? Endometriosis is the presence and growth of the glands and stroma of the lining of the uterus in an aberrant or heterotopic location. So what we know is that the glands and the stroma of the lining of the uterus, or what we call the endometrium, should be confined within the endometrial cavity or the uterine cavity. Now, if we see these glands and stroma of the endometrium outside the uterine cavity, such as in the ovary, the fallopian tubes, the colon, the bladder, and everywhere else, as long as it's outside the endometrial cavity, then that's endometriosis. Endometriosis is a benign disease, yet it has the characteristics of a malignancy, that is, it is locally infiltrative, invasive, and widely disseminating. The growth of ectopic endometrium is stimulated by physiologic levels of estrogen. Endometriotic implants are mostly seen in dependent portions of the female pelvis, and the ovaries are the most common site of endometriotic implants. There are three cardinal histologic features of endometriosis, and these are ectopic endometrial glands, ectopic endometrial stroma, and hemorrhage into the adjacent tissue. And these are the common sites for endometriotic implants. So we have the ovaries, as I've already mentioned. We have the pelvic peritoneum, ligaments of the uterus, sigmoid colon, appendix, pelvic lymph nodes, cervix, vagina, and fallopian tubes. And the not so common sites or the rare sites will be the umbilicus, episiotomy scar, bladder, kidney, lungs, arms, legs, nasal mucosa, and spinal column. About 10% of reproductive age women have endometriosis, and endometriosis has been reported in up to 40% of adolescents with genital tract anomalies, up to 50% of women with infertility, and up to 70% of women and adolescents with pelvic pain. So basically, we have three phenotypes for endometriosis. We have the superficial or peritoneal lesions, the endometriomas or the OMA, and the deep infiltrating endometriosis or the DIE. So the superficial lesions, the color of the lesion varies widely and may be red, brown, black, white, yellow, pink, clear, or a red vesicle. The predominant color depends on the blood supply and the amount of hemorrhage and fibrosis. The color also depends or appears related to the size of the lesion, the degree of edema, and the amount of inspissated material. Endometriosis, on the other hand, are ovarian cysts that may range anywhere between 1 cm to 8 cm or probably larger than 8 cm in diameter. The associated adhesions may be filmy or dense, and larger cysts are usually densely adherent to the surrounding pelvic sidewalls or broad ligament. The DIE, or the deep infiltrating endometriosis, are endometriotic implants that are with a penetration of greater than 5 millimeters and represent a more progressive or aggressive form of the disease. Now we talk about the pathogenesis of endometriosis with emphasis on the theories on the development of endometriosis. Here are the theories for the development that explain the development of endometriosis. So we'll discuss this one by one. First is the retrograde menstruation. So this is also called the Samson's theory of retrograde menstruation, and this is the most popular theory. So this theory states that the reflux of menstrual blood and viable endometrial cells in the pelvis leads to implantation of endometrial cells in the pelvic peritoneum, and under hormonal influence, they grow as homologous grafts. Now, some examples of cases that are evidence of retrograde menstruation are the following. So endometriosis is mostly discovered in areas immediately adjacent to the tubal ostia or in the dependent areas of the pelvis. And also endometriosis is frequently found in women with outflow tract obstruction. So this is a very nice illustration explaining how peritoneal endometriotic implants are established via the theory of retrograde menstruation. So we have here the endometrial stem cells from the menstrual fluid that reach the peritoneal cavity. So once they reach the peritoneal cavity, they are activated and infiltrated by inflammatory and immune cells. So they grow in number and in size, and they implant by the process of angiogenesis and anti-apoptosis. So these endometriotic implants grow as homologous grafts in the site of implantation. So endometriotic tissues are known to have an aromatase enzyme that converts androgen to estradiol. And they also have a increased activity of COX-2 enzyme that leads to the secretion of higher levels of prostaglandins. So the secretion of prostaglandins leads to the feeling of pelvic pain among patients with endometriosis and also fibrosis and scarring. So as I've already mentioned, endometriotic implants, its gross appearance depends on the site, activity, relationship to the day of the menstrual cycle, and the chronicity of the area involved. The color of the lesion may be varied. They can be red, brown, black, white, yellow, pink, or a reddish or a clear vesicle. The color depends on the blood supply, the amount of hemorrhage, fibrosis, size of the lesion, and degree of edema, and the amount of inspissated material. So the new lesions are small, bleb-like implants that are less than 1 centimeter in diameter. The red, blood-filled lesions are the most active phase of the disease, and this is an example of that lesions. The dark brown, the dark blue, or the black lesions are described as powder burn areas, such as this picture here. And the older lesions are the white lesions here, and they have the most intense scarring and are usually puckered or retracted from the surrounding tissue. The white or mixed colored lesions are more likely to provide histologic confirmation of endometriosis. Next, we have the theory of coelomic metaplasia. This theory states that endometriosis may arise from metaplasia of the coelomic epithelium or proliferation of embryonic rest. The Mullerian ducts and nearby mesenchymal tissue form the majority of the female reproductive tract. And we all know that the Mullerian duct is derived from the coelomic epithelium during fetal development. So the metaplasia hypothesis postulates that the coelomic epithelium retains the ability for multipotential development. Now, it is well known that the surface epithelium of the ovary can differentiate into several different histologic cell types. Metaplasia occurs after an induction phenomenon has stimulated the multipotential cell, and the induction substance may be a combination of menstrual debris and the influence of estrogen and progesterone. It has been hypothesized that the histogenesis of endometriosis in peritoneal pockets of the posterior pelvis results from a congenital anomaly involving rudimentary duplication of the Mullerian system, and the peritoneal pockets that they describe are found in the posterior pelvis, the posterior aspects of the broad ligament, and the cul-de-sac. And similarly, it has been postulated that metaplasia of the coelomic epithelium that invaginates into the ovarian cortex is the pathogenesis for the development of ovarian endometriosis. So some of the examples of endometriosis cases that can be explained by coelomic metaplasia are the following. So endometriosis has been discovered among prepubertal girls, among women with congenital absence of the uterus, and very rarely among men. Decidual reaction of isolated areas of peritoneum during pregnancy is also an example of this process. The third theory is the lymphatic and vascular metastasis. This theory helps to explain rare and remote sites of endometriosis such as the spinal column, the nose, pelvic lymph nodes, forearm, thigh, and multiple lesions in the lung. So this endometriosis of the lungs usually leads to catamenial hemothorax, which means that there is a bloody pleural fluid that occurs during menstrual periods of the patient with multiple lesions of endometriosis in the lungs. The fourth theory is iatrogenic dissemination, and this theory states that endometrial glands and stroma may be implanted during a surgical procedure, so such as when the OB-gynecologist performs a cesarean section, where endometriotic tissues may implant in the skin or the subcutaneous layer, and even during a normal spontaneous delivery when the obstetrician gynecologist performs an episiotomy. So the endometriotic tissues may implant along the episiorophy scar. The fifth theory is immunologic changes, or the immunologic theory. And this theory proposes that the changes in the immune system, especially altered function of immune-related cells, are directly related to the pathogenesis of endometriosis. Now, studies have demonstrated abnormalities in cell-mediated and humoral components of the immune system in both the peripheral blood and peritoneal fluid. So this box here, or this table here, depicts various cytokines and growth factors that have been implicated in the pathogenesis of endometriosis. So most likely, the primary immunologic change involves an alteration in the function of the peritoneal macrophages that are so prevalent in the peritoneal fluid of patients with endometriosis. So it has been hypothesized that women who do not develop endometriosis have monocytic type macrophages in their peritoneal fluid that have short lifespan and limited function. On the other hand, women who do develop endometriosis have more peritoneal macrophages that are larger. And these hyperactive cells secrete multiple growth factors and cytokines that enhance the development of endometriosis. And the attraction of leukocytes to specific areas is controlled by chemokines, which are chemotactic cytokines. Now, this is a very nice illustration of what I just mentioned one slide back. So, as you can see here, this is the peritoneal macrophage of a woman with no endometriosis. So, the peritoneal macrophage of a patient with no endometriosis has very limited function. So, it has no or lacks membrane function, it has low expression of enzymes, and there's no increase in the size of the macrophages. However, in a patient with endometriosis, the peritoneal macrophage grows or increases in size. So it becomes bigger, and at the same time, this hyperactive cell secretes growth factors, enzymes, and even cytokines, and all of these contribute to the development of endometrial cells. So these endometrial cells implant and attracts more monocytes. Another attractive theory is the finding of a protein similar to haptoglobin in endometriosis epithelial cells called Endo-1. And this chemoattractant protein enhances local production of interleukin-6, self-perpetuates lesion cytokine interactions. Now, further compounding the proliferative activity of endometriosis lesions are angiogenic factors that are increased in lesions. And here, the expression of basic fibroblast factor IL-6, IL-8, platelet-derived growth factor, and vascular endothelial growth factor are all increased. Steroid interactions also enhance the progression of disease. Estrogen production is enhanced locally in endometriotic implants, and there is evidence of upregulation of aromatase activity, increased COX-2 expression, and dysregulation of 17-beta dehydrogenase activity, where there is a deficiency in 17-beta dehydrogenase 2 activity and possibly an enhancement of type 2 activity favoring local estradiol production. So this is a very nice illustration showing to us the difference between the endometrium of women with no endometriosis versus those with endometriosis. Now, for women with no endometriosis, the endometrium has normal levels of COX-2 or normal activity of COX-2 enzyme. So we have only a low level of prostaglandin E2. There is no aromatase in the endometrium of patients with no endometriosis, and therefore there's no local production of estrogen in the endometrium. And also, in the endometrium of patients with no endometriosis, there is the enzyme called 17-beta-2 hydroxysteroid dehydrogenase, which converts estradiol, the very active form of estrogen, to a less active form, which is estrone. So the effect here will be a very low level of prostaglandin E2 and also very low levels of the active form of estrogen, which is estradiol. Now, let's compare this to the endometrium of women with endometriosis. So in women with endometriosis, the endometrium has increased levels of COX-2 or increased activity for COX-2, and therefore we have higher levels or moderate levels of prostaglandin E2. Also, there is aromatase enzyme in the endometrium of patients with endometriosis, and therefore androgen will be converted to estrogen. So there's local production of estrogen, and also estradiol is converted to estrone in the endometrium of patients with endometriosis. So the effect here will be moderate levels of prostaglandin E2, and also there's low estradiol locally. Now, how about for ectopic endometriotic tissues? So in endometriotic tissues, we have increased levels of COX-2, which produces very, very high levels of prostaglandin E2. There's also aromatase enzyme, which converts androgen to estradiol. And in endometriotic tissues, there is no 17 beta 2 hydroxysteroid dehydrogenase. So there's no local conversion of estradiol to estrone. So the effect here, the overall effect here will be very high levels of prostaglandin E2 and very high levels also of estradiol locally. The enhanced aromatase activity in endometriotic tissues appears to be the result of overexpression of the orphan nuclear receptor steroidogenic factor 1 or SF1 in lesions. Now, the local production of estrogen through the aromatase activity explains why progression of lesions may occur even with ovarian suppression. And more studies now show emerging evidence for progesterone resistance in endometriotic lesions. And this is due to the lack of progesterone receptor in endometriotic lesions. So because of that, stromal cells of endometriosis are not capable of responding to progesterone by formation of sufficient quantities of retinoic acid and other paracrine factors because of the deficiency in the levels of progesterone receptor. Now, because of this, consequently, the 17 beta 2 hydroxysteroid dehydrogenase promoter in epithelial cells is not activated. Now, if this is not activated, then there will be very, very high levels of estradiol because there's no enzyme to convert estradiol to the less active form, which is estrone. Autoimmunity may well exist also in women with endometriosis, and there are reports of increased B and T cells and serum immunoglobulin IgG, IgA, and IgM autoantibodies in endometriosis. And there's also evidence of the higher prevalence of other autoimmune diseases among women who are diagnosed to have endometriosis. Now, the final theory will be genetic predisposition. And this theory postulates that there is familial predisposition to endometriosis with grouping of cases of endometriosis in mothers and their daughters. The incidence of endometriosis in first-degree relatives, women with severe endometriosis, have been thought to be 7%. Women who have a family history of endometriosis are likely to develop the disease earlier in life and to have more advanced disease. And studies show that there is a deletion of genes, most specifically increased heterogeneity of chromosome 17 and aneuploidy among women with endometriosis compared with controls or compared with women with no endometriosis. Now we go to clinical diagnosis of endometriosis. First, of course, is we do a thorough history of our patient, and the classic symptoms of endometriosis are cyclic pelvic pain and infertility. Now, chronic pelvic pain usually presents as secondary dysmenorrhea or dyspareunia or both. Secondary dysmenorrhea usually begins 36 to 48 hours prior to the onset of menses, and approximately one-third of patients with endometriosis are asymptomatic. The cyclic pelvic pain is related to the sequential swelling and the extravasation of blood and menstrual debris into the surrounding tissue. The chemical mediators of this intense sterile inflammation and pain are believed to be prostaglandins and cytokines. The extent of pelvic pain is often inversely related to the amount of endometriosis in the female pelvis. Dyspareunia associated with endometriosis is described as pain which is deep in the pelvis, and the cause of the symptom seems to be the immobility of the pelvic organs during coital activity or direct pressure on the areas of endometriosis in the uterosacral ligaments or the cul-de-sac. So apart from doing a thorough history and physical exam, we can also request for imaging. And imaging can be a useful adjunct to the clinical presentation and physical exam for evaluation of endometriosis. Transvaginal ultrasound exam should be the first line diagnostic imaging because this has the highest sensitivity and specificity in identifying ovarian endometriomas, and transvaginal ultrasound is very helpful in differentiating solid from cystic lesions and may help distinguish an endometrioma from other adnexal abnormalities. And because the lesions are vascular, increased Doppler flow may be demonstrated in endometriosis. There are 4 ultrasonographic steps to the evaluation of the pelvis with suspected endometriosis. First is the traditional evaluation of the uterus and adnexa for adenomyosis or endometriomas. Now, adenomyosis is observed more frequently in women with deep endometriosis lesions compared with those with superficial lesions. And the second step is the ultrasound probe is used to determine the location of specific tender spots that may reflect disease-specific sites to be investigated at the time of surgery. The third step will be evaluate the cul-de-sac or the pouch of Douglas to determine whether there is deeply infiltrating disease or obliteration by the sliding sign, where in which the pressure is placed on the cervix with the probe to see whether the anterior rectum moves freely across the area of the vagina next to the posterior cervix and the upper uterus. And the fourth step will be evaluation for nodules of the anterior compartment or the bladder and the posterior compartment. Now, the posterior compartment includes the uterosacral ligaments, the rectovaginal septum, the vaginal wall, and the rectum. Now, modified techniques such as rectal water contrast transvaginal ultrasound can increase the probability of detecting a DIE lesion, which is now considered to be the more sensitive technique for the diagnosis of DIE. Now, MRI provides the best overall diagnostic tool for endometriosis, but of course, because of expense, is not always a practical modality for its diagnosis. Now, the use of MRI seems logical for equivocal ultrasound findings, especially if surgery is planned for excision of deeply infiltrating endometriosis, possibly requiring rectal or bladder resection. We can also do diagnostic laparoscopy for the diagnosis of endometriosis. Now, when laparoscopy is undertaken to establish diagnosis of endometriosis, it is very important to describe systematically the extent of the pathology. The ASRM developed a point scoring designed primarily to record the extent of the disease in infertility patients. Now, the focus here is intended to provide characterization of disease extent for fertility and not for pain assessment. So we also have the EFI, which focuses on the fertility potential of the patients with endometriosis, and it has been shown in prospective evaluation to correlate well with pregnancy rates. Now let's talk about the differential diagnosis of endometriosis. So although this is a benign disease, endometriosis exhibits characteristics of both malignancy and sterile inflammation. Therefore, the common considerations in the differential diagnosis would include chronic pelvic inflammatory disease, ovarian malignancy, degeneration of myomas, hemorrhage or torsion of ovarian cyst, adenomyosis, primary dysmenorrhea, and functional bowel disease. Occasionally, a large endometrioma of the ovary may rupture in the peritoneal cavity, and this results in an acute surgical abdomen and brings into the differential diagnosis conditions such as ectopic pregnancy, appendicitis, diverticulitis, and a bleeding corpus luteum cyst. Now we talk about some biomarkers for endometriosis. One of the more common biomarkers that we use is CA125, and the levels of CA125 are elevated in most patients with endometriosis, and the levels increases incrementally with advanced stages of endometriosis. However, CA125 has very low specificity for endometriosis because it is also found to be increased with other pelvic conditions such as leiomyomas, acute pelvic inflammatory disease, first trimester pregnancy, and of course, cancer. Glycodyline also is a biomarker for endometriosis, and this is previously known as placental protein 4. And this has been shown to be elevated in endometriosis and is produced in endometriotic lesions. And the most predictive markers appear to be IL-1 or interleukin-1, which is the most useful marker, chemoattractant protein 1, and interferon gamma. Now we go to the staging of endometriosis. The most common staging that we use for endometriosis is the ASRM, or formerly known as the AFS staging. So we have here minimal, mild, moderate, or severe, or stage 1, stage 2, stage 3, stage 4. So for stage 1 or the minimal, this is a presentation of 2 to 3 superficial implants. With stage 2 or mild, this is the appearance of more implants that occur within the deeper layers of the tissue. Stage 3 or more moderate, these are the note of many deep implants in combination with minor or small endometriomas on one or both ovaries, and may also present filmy adhesions. Now, the last stage will be stage 4, where this is also called the severe endometriosis, where there is persistence of deep implants, enlargement of endometriomas on one or both ovaries, and the development of dense adhesions. We also have the ENZIAN staging, and the ENZIAN staging is used as a supplement to the ASRM or AFS staging that we already mentioned one slide back. And this system is usually used to analyze DIE, or the deep infiltrating endometriosis. Now, this grades the disease by the diameter of the nodules and localization. So next, we have the EFI staging, or what we call the Endometriosis Fertility Index. So this scoring system estimates the woman's chances of pregnancy after laparoscopic surgery or open surgery to remove endometriotic lesions. So we have the factors that we consider here are the ASRM staging, of course, the age of the patient, the duration of infertility, previous pregnancies, and the lesions in the fallopian tube, the fimbria, and the ovary. So this scoring system can help identify patients who are best candidates for in vitro fertilization. Finally, we go to the treatment of endometriosis, whether it be medical or surgical treatment. The two primary short-term goals in treating endometriosis are relief of pain and the promotion of fertility. And the primary long-term goal in the management of endometriosis is, of course, attempting to prevent progression of the disease or preventing the recurrence of the disease process. Treatment of endometriosis can be medical, surgical, or usually a combination of both. Selection of an optimal treatment is based on multiple factors, and this includes, of course, the patient's age, patient preference, the reproductive plans of the patient or the couple, pain severity, the degree of the disease, treatment cost and intended duration, treatment risk or side effect profiles, and of course, accessibility. So first, let's talk about medical treatment. The main objective of medical treatment is to prevent recurrence and reduce symptoms, thereby eliminating the need for surgery or repeat surgery or prolonging the time between surgeries. Now, the aim of medical treatment is to suppress lesions and associated symptoms, particularly pelvic pain. Now, a few slides back, I've already mentioned that endometriosis is very, very dependent on the estrogen levels. And therefore, the goal of hormonal treatment is to induce a local hypoestrogenic state by suppressing ovulation, or what we call menstrual suppression, thereby inducing amenorrhea. Now, the resulting amenorrhea or hypomenorrhea reduces the conversion of arachidonic acid to prostaglandins with menses, and subsequently, this will lessen dysmenorrhea and pelvic pain. Medical therapy usually suppresses symptomatology and prevents progression of endometriosis, but it does not provide a long-lasting cure of the disease. Unfortunately, once suppressive therapy is stopped, then symptoms tend to recur at variable rates. Now, the first medical treatment that we will discuss is the oral contraceptives. And incidentally, this is one of the most common treatment that we offer patients with endometriosis. And because of its hormonal components, it creates a pseudo-pregnancy effect. And it has been accepted that the most economical regimen for the treatment of women with mild or moderate symptoms of endometriosis has been a continuous daily oral contraceptive for 6 to 12 months. And continuous dose regimens are aimed at more complete suppression, and the only concern is with breakthrough bleeding that is common in oral contraceptive use. The one potential risk of using oral contraceptives or progestogens is that there is some risk of rupture if a large endometrioma is present, and rupture of large endometriomas may result in an acute surgical abdomen during the first 6 weeks of oral contraceptive therapy. Now, during prolonged therapy, the endometrial glands atrophy and the stroma undergoes a marked decidual reaction. Now, some smaller endometriomas, those that are less than 3 centimeters in diameter, can undergo necrobiosis and eventually resorption. The most common side effects of oral contraceptives are weight gain and breast tenderness. Now, for women who fail combined hormone therapy, for those smokers who are older than 35 years of age, and women with predisposing risk factors for myocardial infarction, stroke, or thrombotic events, and therefore we don't want to give them any estrogen-containing treatment, we can give progestins or progestogens. Okay, so these are hormonal therapy without estrogen, of course. So we give progestogen alone. So we can give this through oral, intrauterine, parenteral, or implantable routes, and all have breakthrough bleeding as the most common side effect. And breakthrough bleeding can be ameliorated with a 7 or 14-day course of a low dose, very low dose estrogen. Some authors suggest that progestin-only methods such as norethindrone acetate and of course the Unogest may be superior to COCs and can be considered first line, especially in women with rectovaginal and extrapelvic endometriosis. Now, some of the examples of progestogens or progestins that we can give are the following: medroxyprogesterone acetate, that's an oral form. And then we can also give the depot form of medroxyprogesterone acetate. We can give norethindrone acetate, gestrinone, and Dienogest. Next, we have GnRH agonist, and the use of this medical treatment leads to a dramatic reduction in estrone, estradiol, testosterone, and androstenedione to levels that are similar to the hormonal levels in oophorectomized women. Therefore, the use of GnRH agonists usually gives the effect of a medical oophorectomy. And GnRH agonists have no effect on sex hormone-binding globulin. Thus, the androgenic side effects from DANAZOL caused by the increase in free serum testosterone are not observed. And similarly, no significant changes occur in total serum cholesterol, HDL, or LDL levels during therapeutic periods for as long as 6 months. Examples of GnRH agonists that we can give our patients are the following: leuprolide acetate, nafarelin acetate nasal spray, and goserelin acetate. Now, the side effects that are associated with giving of GnRH agonist therapy are primarily those associated with estrogen deprivation, similar to menopause. And the 3 most common symptoms are hot flashes, vaginal dryness, and insomnia. Next, we have NSAIDs, or the non-steroidal anti-inflammatory drugs. Of course, NSAIDs are always the go-to drug for pain relief and control of bleeding. And the rationale for this is that the lesions of endometriosis have been found to express high levels of COX-2, as I've already mentioned a few slides back. And therefore, this is the reason why NSAIDs are very useful in pain relief and control of bleeding also. Next in our medical armamentarium is DANAZOL. DANAZOL is actually an attenuated androgen which is active only when given orally. This produces a hypoestrogenic and hyperandrogenic effect. Now, the androgenic and anabolic effects of this drug has limited its modern day use, and therefore this type of treatment has already fallen out of favor for most OB-gynecologists because of its androgenic side effects. Now, this drug induces atrophic changes in the endometrium of the uterus and similar changes in endometrial implants. It may also modulate immunologic function. The dose is about 400 to 800 milligrams daily for 6 to 9 months, but many clinicians reduce the total daily dosage of the drug down to 200 because of its androgenic and anabolic side effects. Okay, this is a very nice table that summarizes the medical treatment or the medical options that we can give for our patients with endometriosis. So I've already mentioned number one, the oral contraceptive pills or the estrogen-progestin combinations. And we have here the mechanism of action as stated here, ovulation inhibition and decidualization or atrophy of lesions. And the dose will be a continuous orally daily and the side effects. So we also have discussed progestins, and this will be the mechanism of action as already mentioned, and the different progestins that we can give and their corresponding doses and the side effects. We also mentioned GnRH agonist. The mechanism of action is here, the drugs that we can use, the doses, and the side effects. Now, here are some of the other medical treatment that we can offer our patients with endometriosis. We can offer GnRH antagonist, which inhibits gonadotropin secretion and subsequently downregulates ovarian steroidogenesis. This is a relatively new drug in the market, and it comes in the form of elagolix, which is given at a dose of 150 milligrams once a day. Side effects include hot flashes, lipid abnormalities, decreased bone density. Another medical treatment that we can offer are the aromatase inhibitors. A few slides back, I've already mentioned that endometriotic lesions or endometriotic tissues have local aromatase enzymes that converts androgen to estradiol. And therefore, no, these endometriotic lesions have local production of estradiol. And therefore, to block that conversion, we can give aromatase inhibitors. So, aromatase inhibitors produces a local blockade of the enzymatic conversion of androgens to estrogen. And we can give either letrozole or anastrozole, and these are the doses. However, the side effects would be hot flashes, headaches, decreased bone density. I've already mentioned DANAZOL as one of the forms of medical treatment for endometriosis. And finally, we can also give selective progesterone receptor modulators. They inhibit ovulation, and they are also agonists or antagonists at the progesterone receptor. We can either give mifepristone or ulipristal acetate, and these are their doses. And their side effects would be spotting, cramping, dizziness, headache, and nausea. Now we go to the surgical treatment of endometriosis. Now, surgical treatment is indicated only for the following. So, after failure of empiric therapy or empiric medical therapy, failure or intolerance of medical management, for purposes of diagnosis and immediate treatment, and of course for diagnosis and treatment of an adnexal mass and treatment of infertility in some patients. Surgical therapy is divided into conservative or definitive operations. So we have the conservative surgery, which involves resection or destruction of endometrial implants, lysis of adhesions, and attempts to restore normal pelvic anatomy. On the other hand, the definitive or extirpative surgery involves the removal of both ovaries, the uterus, and all visible ectopic foci of endometriosis. And this is analogous to cytoreductive surgery in ovarian carcinoma. Now, if the patient has midline pain such as dysmenorrhea or dyspareunia, presacral neurectomy or resection of the uterosacral ligaments may be performed. Ablation of the uterosacral nerves when performed via laparoscopy is called laser uterosacral nerve ablation. And presacral neurectomy relieves only midline pain and does not diminish pain in other areas of the pelvis. So other surgical treatments that we can offer our patients are ovarian cystectomy or oophorecystectomy when patients present with endometriotic cyst, or total hysterectomy with bilateral salpingo-oophorectomy or THBSO for patients who do not desire future pregnancy. So that's it for my lecture. So in summary, we have discussed the definition, the pathology, the etiologies or theories for the development of endometriosis, differential diagnosis of endometriosis, how to clinically diagnose endometriosis, and finally, the surgical and medical treatment of endometriosis. Thank you for watching, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.